The broadcast is now starting. All attendees are in listen-only mode.
Hi there, my name's Pam Durepos. Can everybody hear me? Okay, so we're going to begin this presentation, which is about my research project entitled Carrying Ahead, Development of a Questionnaire to Measure Death Preparedness in Family Caregivers of Persons with Dementia. That's a huge mouthful, I realize. Thank you so much for joining today, and thank you for this great opportunity from my supervisor, Dr. Sharon Kesalainen, to present to you on this special research project. So before we start, there is a tab to ask questions. If possible, I'd like to answer all the questions at the end, but please do submit them so we can have a bit of a discussion. And also there will be a short survey at the end of the presentation so that I can get a little bit of feedback just about how you found the presentation and to give me some ideas for improvement in the future. So that'll pop up for you when this is completed, and I love to have a little bit of feedback from you. So for this research project, my most biggest acknowledgements have to go to my supervisor, Dr. Sharon Kesalainen, who is an investigator on the iCAN-ACP project. She's been my supervisor through my PhD, and also previous to that for my master's. And I also have committee members who are involved in the iCAN-ACP project, in particular Dr. Tamara Sussman, who is at McGill University. I also need to acknowledge my funders, most importantly the Canadian Frailty Network, who's very generously allowed me to act as an interdisciplinary fellow this year. So I'm doing a fellowship with them, which has been a really valuable experience, and also CIHR through a doctoral fellowship award. I'm also being supported by the Alzheimer's Society, Shalom Village, the Canadian Nurses Foundation, and the School of Nursing at McMaster. And all of these great funding opportunities have really allowed me to focus on my research and really try to progress this area of research to the benefit, hopefully, of family caregivers and people with dementia out there. So hopefully from this presentation, I hope to share with you some unique characteristics of caregivers of people with dementia and why they, might require a little bit more care or thought or attention. Hopefully to discuss and increase your understanding of how we perceive death preparedness is as a theoretical construct, to recognize limitations in existing measurement tools, and then also hopefully to have you consider using death preparedness as a holistic outcome for interventions of advanced care planning that can be applied prospective to death, so that hopefully we can target people who may need more support and care prior to death. Okay, so just a general outline for the presentation today, always some background work before getting to the actual research project. Then I'm excited to tell you about our design methods and some early findings about what this questionnaire may actually look like when we're finished this project. So just to tell you a little bit about myself, I am a nurse. I began my PhD in 2016, supervised by Dr. Sharon Kesalainen. I'm still working as a nurse in the neurotrauma intensive care unit at the Hamilton General Hospital. And it was really through my work there that I became very interested and passionate about working more in palliative care, focusing more on healing than curing. Particularly, we work with a lot of people with, end-stage COPD, heart failure, dementia, and also people with traumatic brain injuries, where our focus really is on quality of life as opposed to trying to cure, incurable symptoms or diseases. So I've had the great opportunity through the past few years of working with Dr. Kesalainen on the Strengthening a Palliative Approach to Long-Term Care project, which is, progressed into multiple other projects now. And within those projects, I've had the opportunity to look at what feasibly are sort of related to advanced care planning initiatives like family care conferences and long-term care. And so they're really, strongly related to my research now. So I feel like when I do the presentations on this, I need to sort of provide a preamble, because talking about preparedness really, it can get people's backs up, because it's preparing for death is not as simple or as easy an event to prepare for as many other things we look at. You can just fill out a checklist and then feel that you're very much prepared. So I reflect on this quote that came from a bereaved family caregiver who shared with me, "In the whole process of his illness, I think you're preparing for many years that death is inevitable. But at the end, nothing really prepares you for the actual dying, because you don't know how you're going to feel." So I sort of present that as this preamble and this idea that you can never feel 100% prepared. However, there are things that caregivers recommend doing to help yourself adjust and cope with the approaching loss of a loved one. And we as healthcare professionals can really help support and improve that process for them. So just to recall a little bit about the numbers about dementia in Canada, I know you're all very much experts in this area, many of you coming from the long-term care field yourselves. In Canada, the numbers are rising. We have, at least 587,000 Canadians living with dementia. The majority of those people die in long-term care, and there's a huge total cost to healthcare services and funds lost to families in caring for people with dementia. Particularly for family caregivers, we see different negative health symptoms developing related to caring, such as burden, depression, complicated grief, and other comorbidities. And we also know that end-of-life care is often suboptimal for people with dementia. And across Canada and worldwide, there's very many initiatives going on to improve end-of-life care, most often through initiatives like advanced care planning, where hopefully we are, creating avenues for discussion and thought and planning around what people's values and preferences are for care and treatments that they might receive at end of life. And a huge goal of those interventions that I perceive is also to prepare caregivers for end-of-life experiences. So just in looking a little bit at how family caregivers of people with dementia care compare to other caregivers, we do see that behavior problems are predictive of caregivers developing depression or physical health problems. We also see that dementia is related to a high level of caregiver burden, and also that people who are caring for those with dementia often have an increased or accelerated chance of developing frailty. And we also, in looking into bereavement, can see that there's quite a substantial influence on bereavement even after caregiving has ended. Family caregivers are commonly developing complicated grief, which is intrusive grief that interferes with function. So everyone is assumed to go through a normal grieving process. However, there are people who get sort of stuck in their grief and then may have a prolonged grieving experience, which may even culminate in, things like suicide or other real problems adjusting to a different life. And we see that those rates of prevalence of complicated grief in family caregivers of people with dementia are comparable to other caregivers as well. So we definitely see over the past few years that there's an increasing interest in this variable of death preparedness. There's a really great systematic review conducted in 2016 by Nielsen et al. And he looked at studies where preparedness for death was a variable, along with looking at anticipatory grief as a variable. And as you can see there, the rising interest between 2011 and 2015, there were 10 studies published which looked at death preparedness as a variable. They're also seeing statistically significant results with correlations and predictive relationships where death preparedness has been looked at as a variable. Some of these studies have involved people with dementia. However, these studies are most often using single item global scales to rate how prepared caregivers felt, or they're using the preparedness for caregiving scale, which doesn't actually focus on preparedness for death, but only for caregivers' tasks and such. So just looking a little bit more at this relationship between preparedness for death and outcomes following that into bereavement, we do see a increased odds ratio of how prepared caregivers feel for whether they will develop complicated grief and depression. And we also see here that there has been a measured relationship between an advanced care planning index and how prepared caregivers feel for death. However, only the one study here, Schultz et al. In 2015, actually measured preparedness for death prospective to death. The rest of the studies have looked at preparedness for death only after the person has died, and they've gone back and asked the caregivers, well, how prepared did you feel? So we've got those, concerns about retrospective sort of analysis and asking people to recall what their feelings were. Yeah, and just a few more variables to show how this preparedness for death has really been linked to complicated grief, depression, a caregiver's ability to manage their households, and active coping. So it's quite a valuable variable to be looking at. So in creating our problem, though, we still understand that family caregivers and people with dementia are often experiencing suboptimal end-of-life care. And the reasons that care may be suboptimal are related to poor pain management, limited prognostication, caregivers expressing unmet needs. And we see that in one study, they rated about 23% of caregivers reported feeling unprepared for death, and only 15% of caregivers who expected death in the next 6 months actually discussed it with end-of-life staff at their long-term care home, which suggests that healthcare professionals really need to be initiating these conversations, because family caregivers are often too overwhelmed or unsure or embarrassed to be raising questions about their family members' end of life. So the problem that we recognize is that advanced care planning does aim to improve end-of-life care, quality of dying, provide treatment that aligns with wishes and values, and promote preparedness of the caregiver. However, we don't have a really holistic outcome measure of advanced care planning effectiveness or for preparedness for death. So the process of this study, we're hoping to develop and evaluate a multidimensional questionnaire to measure preparedness for death in caregivers of people with dementia. And our hopes are that this questionnaire will act as an outcome measure for ACP effectiveness. It will help us to identify caregivers with limited areas of preparedness in need of intervention, and then it will allow us to guide and target ACP interventions towards specific areas where people are feeling unprepared. So, of course, every study starts with delving into the literature to see what it is that we already know, and what remains to be sort of researched and explored. So to try to gain a really good understanding of what death preparedness actually means, we conducted a concept analysis of literature. And through that concept analysis, we identified the theoretical framework of preparedness for end of life. And that's been really paramount to conceptualizing what preparedness is, and has really sort of been the great starter to this research project. And then we have also reviewed existing instruments to see if we do in fact need to create one, or if another instrument can be revised or utilized to measure death preparedness, specifically in caregivers of people with dementia. So the first part of that literature review was just published recently. The concept analysis looking at what does death preparedness mean for family caregivers of people with dementia. So we started off with this broad definition that death preparedness means feelings of readiness and awareness for death. And that stems from Berry et al. Back in 1997. And the really interesting thing about that study, when that first definition came out, was that Berry was one of the first people to describe preparedness as a feeling, as opposed to healthcare professionals who used to say, well, this was an expected death, therefore the person was prepared. And so it was more a judgment call from the healthcare professionals' points of view, whereas he acknowledged that no, it's actually a feeling, and regardless about what our perceptions are, caregivers have different feelings about how emotionally, practically, spiritually ready they are for their loss. So we've expanded upon that definition, stating that caregiver preparedness for death and dementia is a cognitive, behavioral, and emotional quality or state of readiness to maintain control and self-efficacy in the face of loss and death. So again, that's quite a mouthful. I'm going to break that down a little bit more as we talk about the literature and how we got there. So we started with this theoretical framework of preparedness for end of life that was developed by Hebert et al. In 2006. And I came across this framework back in my master's. It's been 4 years or so of me looking at this framework, and it just it really spoke to me as being accurate and helping me to understand this concept in a way I had never thought about it before. So basically, we start from a place of uncertainty, and caregivers have concerns that range from medical, practical, psychosocial, and spiritual concerns. And then through end-of-life conversations with, staff and healthcare professionals and other family members, and with the person who may be dying, conversations about prognosis, advanced care planning, spiritual concerns, grief and loss. Hopefully those uncertainties are addressed and they come to a place of preparedness where they feel that they do have self-efficacy and control over medical concerns, practical concerns, psychosocial and spiritual problems or events that may occur. And beneath that are cognitive, affective, and behavioral traits. So things like they have enough information, they have emotional regulation skills, and they are participating in active tasks to actually plan and become ready for their loss. And then, as we've seen from some of the quantitative studies that I indicated at the beginning, we do see relationships that have been proven between caregiver feelings of preparedness and caregiver outcomes following bereavement, including satisfaction with clinical care and caregiver mental health and adjustment. So using that theoretical framework as a foundation, and then also collecting 63 other articles from the literature which talked about family caregiver experiences at end of life and dementia, our main goal was to identify what the actual characteristics of preparedness are. So we identified 7 different characteristics here that range across these different domains. And for example, knowing and recognizing decline in dementia and what dying looks like, and all the way down to closing, reconciling, and renewing relationships and completing the family member's life. We also identified what we felt the antecedents to these characteristics were and what the consequences or outcomes of preparedness may be. And in looking more at these traits that hadn't really been defined well by Hebert et al., we classified them as problem and emotion-based coping strategies to cope with an impending loss. So we've got our cognitive, and information seeking, affective, which is more emotional based, emotional regulation, perhaps mindfulness or feeling that you can cope with grief experiences, and then the actual behaviors, which are again are more problem based coping of actually seeking out resources and finding avenues to prepare and support yourself. So now that we felt we had a fairly good understanding of what this concept might look like, we then were able to assess and evaluate the existing instruments that were out there. So most often people have used a single item global scale to assess death preparedness. However, the problem with single item global scores are that they are generally unidimensional. They require abstract thinking from the participant, and then they may not tap all of the constructs or domains that we have identified are important to that overall, construct or feeling of preparedness. And our goal through this project is to develop something that is multidimensional. So it will actually stimulate reflection from the caregiver on, well, have I thought about my spiritual needs? Have I thought about my psychosocial needs? And they may, exclude those ideas when if just given a global rating score. The score that's most commonly used, as well as the global rating score, is the Preparedness for Caregiving Scale. However, I'm going to show it to you on the next slide, but it does not sample the spiritual domain, and it only has one item sampled for the practical domain. So I'll flip over here. So this is just an example of a content validation matrix that we created for one of these tools. So basically across the top, we have our domains and what we perceive as the underlying traits of preparedness. And then along the side there are the different items of the scale. And we just have checked off which domain or trait we feel that item might sample. And so I just mentioned there that it didn't sample the spiritual domain at all through these items. And then there's also, we get into looking a little bit at the specificity, that there's no questions specifically aimed at looking at dementia or looking specifically at death. They talk a lot about the future, which can be helpful, but is not necessarily the same as contemplating the actual loss of the individual. So overall, in looking at the gaps in what's out there right now, we identified that the preparedness domains and traits were not really fully operationalized. On a questionnaire, we should have some items that are specific to dementia, and the existing instruments are not based on the theoretical framework of preparedness for end of life, which gives them limited utility as measures of preparedness specifically for death. So that brings us to our research questions for the actual study, which are to discern what the dimensions, core concepts, and traits of preparedness for end of life are, as perceived by actual caregivers of people with dementia. What of these characteristics and behaviors can be included on a questionnaire, and what would the validity and reliability of the questionnaire be when it is developed to measure preparedness for end of life. So in order to develop this questionnaire, we're using a mixed method study design, starting out with a qualitative phase and now into 2 different quantitative phases. It's being guided by the instrument development construct validation framework, which has been really valuable in sort of increasing the rigor of the study and using each different phase to sort of legitimize and increase the confidence in the findings from the previous phase. We've used different elements of sampling, including purposive, maximum variation, criterion, and snowball sampling. And long-term care staff are really acting as the gatekeepers to our sample throughout the phases. So as I mentioned, the very first phase was to develop the questionnaire through qualitative interviews with bereaved caregivers. So last summer, we conducted interviews with 16 bereaved family caregivers and then analyzed those interviews with direct content analysis using the different attributes that we identified as important to preparedness to see how they were sort of represented in actual interviews and conversations with caregivers. And then we translated the findings into questionnaire items. So initially we had 141 questionnaire items generated, and then through discussion with the committee members and piloting a draft questionnaire with a caregiver and a professional expert, we were able to reduce that to 73 items, and we felt that that was a feasible and adequate number to provide to a Delphi survey panel to help us identify from those items which are really the most relevant and important to be included on a questionnaire. So now we're right into the midst of our Delphi survey with bereaved caregivers and experts. Thus far, we have a sample of 13 participants. Out of the questionnaire was originally sent to, I believe, 28 people. So I've got just a little bit less than 50% of a response rate. So the round one is just finishing up this Friday. And so far, out of the 73 items, we're looking at the content validity index. And we've got about 41 items which have been rated extremely important by 90 to 100% of the participants. So that those items will be looked at again for redundancy, but they'll probably be the mainstay of the questionnaire that ends up going forth for testing in the final stages. And so our next round of the Delphi, where we aim to resolve disagreements about different items, will begin next week. And then the final questionnaire evaluation period, which we've slated to last for approximately a year, we're aiming to test the questionnaire with approximately 200 caregivers recruited from long-term care so that we can perform some psychometrics and hopefully some factor analysis so that we can discern if there really is these underlying traits, kind of as we have hypothesized, and then look for different sort of trends of preparedness throughout different caregiver groups. So just to describe a little bit of what our study sample has looked like so far, we're really aiming to get diversity because we understand that death is a very unique experience to the individual, and we're trying to find commonalities between different groups. So the average age of our bereaved family caregivers that were interviewed in the first phase was 60. We had a fairly even split of males and females. The majority were adult children. It was much harder to recruit the spouses. I think long-term care staff was much more hesitant about approaching spousal caregivers who generally have a harder time after a loss. And so, to be sensitive to them, it was often easier to approach adult children. We recognize that there's a lot of different cultural beliefs around death, and so we were interested in looking at the diversity in culture as well. However, the majority of people that we were able to recruit did have a British background. And then as well, religion plays a part in people's end-of-life experiences and beliefs. And the majority of our sample was Christian, although we were able to get a few participants who described themselves as being Jewish and one person who was Hindu. And we did reach out to different, to Muslim mosques and to a Buddhist temple, because we really feel that that is an important factor in looking at end-of-life experiences. The people had lived in LTC for an average of 3 years, and people had been bereaved for an average of 9.6 months. So we really aim to get as much diversity in this and through our qualitative interviews as we could. And so now in our second part of the study, in the Delphi survey, we've recruited 13 experts and caregivers for a mean age of 57. Respondents have been by majority female, so that may influence our results. We've got 4 caregivers and 9 experts. We tried to purposely recruit experts from different areas and different disciplines that are involved in looking after people with dementia and their family caregivers. So you can see there that we were able to recruit people from medicine, nursing, spiritual care, social work, and psychology. And we also aim to have some people from both academia and with more clinical experience. And we've seen a range of experiences in terms of their length of experience with an average of 20 years. So just to describe to you what our draft questionnaire is kind of looking at like right now, I'm going to share with you some examples of items that have been rated by 100% of the participants as important, which would mean a content validity index of 1.00. And we're also looking at how these items were scored on this Likert scale. So it was a 7-point Likert scale, and we're looking at items that have had a median score of 6 or greater. So potentially we're seeing this scale as having a 5-point Likert scale response for self-report from caregivers. including subscales of medical, psychosocial, spiritual, and practical. We hypothesize that the underlying traits or potentially the loading factors through factor analysis may be cognitive, behavioral, and affective. And we're not 100% sure yet, but we're most likely going to, be able to provide a total mean score of how prepared caregivers feel based on their subscale scores from each of the different domains. So just to remind you how we have characterized our construct here, this really influences the language that we've chosen to use thus far in creating our elements. Many of them include words like confidence and feelings of control to really try to keep the items linked closely to our definition. So some of the items that have emerged as really highly important that are around medical preparations may include, I understand treatment decisions I may need to make for my family member, for example, using antibiotics, intravenous fluid, transferring to hospital, tubes for feeding or breathing. Or caregivers and I have discussed my family member's wishes and goals for the end of life, for example, to focus on lengthening life, comfort, quality of life, or a combination of both. And then it would have the 5-point Likert scale there for people to make their selections. Psychosocial preparations really focus on preparing relationships and making sure you have enough supportive relationships around you, as well as feeling in control of your own emotions and appraising your own feelings about, readiness to cope with death. For example, I feel I have some control over the care of my family member. I feel confident that care providers will provide quality and end-of-life care for my family member. I feel confident that I will receive enough emotional support from care providers when my family member is dying, for example, by listening to my concerns, providing words of comfort, or being present. Spiritual preparations. So it's really difficult to try to define spiritual versus psychosocial. They're very closely related. So some examples of items for spiritual preparations include, I have a plan to honor spiritual, cultural, or religious traditions that my family member would want around dying, if any. I have someone to talk to if I have concerns about the meaning of illness, death, or dying. And I have said the things I need to say to my family member. And lastly, the practical preparations really get into the task-oriented, burial planning and such. So for example, my family member's legal documents are organized. For example, their will, insurance, and birth certificate. I know who to contact if I need help managing my family member's affairs, for example, legal or financial. And I have planned my family member's burial or cremation with service providers. So all of these items are things that came directly from our family caregivers whom I interviewed, and things that they wish that they had done or that they wish that they had known about, or advice that they would give to fellow caregivers who are preparing for a loss. So some of the challenges and things that we have to consider through our study is that this is just a cross-sectional design. Recruitment is always a challenge, particularly in the sensitive time of people are approaching end of life. We don't want to cause any kind of additional distress, and it's also difficult to prognosticate. So while we may assume that people in long-term care may have a few more years to live, people's health can change quite suddenly, and then a caregiver may either not have time to complete the questionnaire, or it may be inappropriate to approach them because it's right at the end of life. In terms of response bias, definitely people are more prone to do some extreme responses. We've seen that even in the Delphi survey. We'll have to make a plan for how to cope with the missing data. And of course, we really just want to be sensitive to people's experiences that are going through this, and really, align with our ethical principles. So the main potential impact of doing this study hopefully is to identify caregivers in need of more intervention before they've experienced a death. We would really like to evaluate how effective our advanced care planning processes and interventions are, if they are increasing the feelings of preparedness for family caregivers. We'd like to be able to tailor our interventions to the specific areas where caregivers are feeling unprepared. A lot of caregivers that I had interviewed had burial plans and funeral plans, but hadn't thought about the impact of losing their family member on their identity or their lack of life purpose after their family member is gone. And many of them wished that they had been more involved in volunteering or socialization or some kind of recreation before their family member had died, so that they would have sort of had this plan for how they would continue on in bereavement as having another identity beyond being a caregiver. So that was some advice that we heard. And perhaps if that was picked up in an intervention that people were feeling they hadn't thought in advance about some of those issues, maybe then we could suggest as healthcare professionals that they find some other kind of avenue to express themselves and have purpose in their life besides focusing only on caregiving. It might help us to guide interventions where we're addressing all of these different domains, and hopefully we'll also be able to explore relationships between each of the domains and specific outcomes. And then, of course, developing this questionnaire hopefully will be useful to researchers, should be instilled into the education of healthcare professionals on what's important to help caregivers do during end of life, which of course holds implications for practitioners. And policymakers are frequently looking for new measures by which to evaluate their strategies that they're advocating for. So some of the publications that have come from this project so far, I mentioned at the beginning, is just the concept analysis. And then I've recently submitted the assessment of existing tools to the Journal of Aging and Mental Health. And there is a poster that we developed for the protocol for this study. Okay, so now I'm going to take a big deep breath and I'll open up if there's any questions. Thank you so much for listening. I'm sorry if I talk fast. Does this topic, does it resonate with people? Do you feel that this would be relevant as an outcome measure for advanced care planning? All right, well, I hear crickets. Maybe everybody needs to go and have their lunch. I've got my contact information here, and I'm more than happy to hear. I would love to hear from anybody about your perceptions of this work. If you think you have any family caregivers or anyone who might be interested in helping with this project or are interested in being a stakeholder in any way, yeah, so please feel free to reach out to me, and I'm also happy to share my slides if anyone would like them. And I just thank you very much for your attention today. Okay, thank you.